Hello, we are at Mother and Child Health Care Institute of Belgrade. I am Maja Miličković. I am pediatric surgeon and assistant professor of surgery.
Hello dear colleagues, my name is Vladimir Kojević, I'm pediatric surgeon and urologist. I'm also assistant professor of surgery at the Institute of Mother and Child Healthcare Institute of Serbia.
This lecture is about abdominal examination in child with abdominal pain. Abdominal pain is one of the most frequent signs or symptoms in pediatric population. Abdominal examination is one of the most frequent things performed by pediatric surgeons. At the beginning, it is necessary to explain in an understandable language to the parents and the child the need for an abdominal examination. It is better not to use personal protective equipment if the situation allows it. The examination must not cause inappropriate pain or discomfort in children. Trust be lost very quickly and further questioning can then be impossible. Position the child lying flat on the bed with their arms by their sides and legs uncrossed for abdominal inspection. Expose the abdomen entirely. Inspect the child's abdomen for signs suggestive of gastrointestinal pathology. There are many different types of abdominal scars that can provide clues as to the child's past surgical history. Observe abdominal distension. It can be caused by a wide range of pathology, including constipation, Hirschsprung disease, ascites, organomegaly, and malignancy. A reminder that the abdomen is normally protuberant in toddlers and young children. In child with portal hypertension, caput medusa, engorged paraumbilical veins can be observed. Observe for any protrusions through the abdominal wall that can be hernia, umbilical hernia, incisional hernias. Observe drains, tubes, stomas, gastrostomy, central venous catheter, ileostomy or colostomy. Observe abdominal wall movements during respirations. Abdominal palpation. Use warm hands. Relax the child and keep the parent close at hand. Abdominal wall muscles must be relaxed for palpation to be effective. For that purpose, flex child's hips to 45 degrees and knees to 90 degrees. Ask the child if they are aware of any areas of abdominal pain. If present, examine these areas last. Observe child's face throughout the examination for signs of discomfort. Tell the child, I am going to feel your tummy. Please let me know if you feel any pain or if you want me to stop. Tip: young children may be more cooperative if you palpate first with their hand. Hello, can you give me your hand to palpate your tummy? We are going to palpate your tummy together. If you are tall or the bed position is low, you might want to kneel down when doing palpation. Palpation can be light and deep. If the child complains of pain in the right iliac fossa, begin palpation of the abdomen from the left iliac fossa and lightly palpate each of 9 abdominal regions in the direction I am now pointing. Left iliac fossa, left lumbar region, left hypochondrium, epigastrium, right hypochondrium, right lumbar region, umbilical region, hypogastrium, and at last right iliac fossa. Examiner's arms are in the position of slight flexion in elbows and the hands of the folded fingers are placed horizontally on anterior abdominal wall. The movements of the hand are gentle, careful, and depressing. Determine the tenderness of the abdominal regions and severity of pain. Tenderness can be localized. For example, tenderness to palpate of right iliac fossa in appendicitis, tenderness to palpation of right upper quadrant in hepatitis, tenderness to palpation of flank in pyelonephritis. Tenderness is generalized in mesenteric adenitis or peritonitis. Determine rebound tenderness, which can be present when the abdominal wall having been compressed slowly and released rapidly and results in sudden sharp abdominal pain. This is a not specific, unreliable clinical sign that can, in some cases, be associated with peritonitis. Determine guarding involuntary tension in the abdominal muscles that occurs on palpation associated with peritonitis, for example, in appendicitis. If palpation of the left iliac fossa causes pain to be experienced in the right iliac fossa, it is indicative of peritoneal inflammation of any cause affecting the left and or right iliac fossa. It can be appendicitis. It is called Rosing sign. Large or superficial masses, for example hernias, may be noted on light palpation. Light palpation is followed by deep palpation of each of 9 abdominal regions. Apply greater pressure for deep palpation and identify any deeper masses. Deep palpation can be performed with both hands, then the fingers of both hands are next to each other. Monitor patient's face for evidence of discomfort because they may not vocalize this. If any masses are identified during deep palpation, assess location, size and shape, consistency, smooth, soft, hard, irregular, and then mobility and pulsatility of the mass. Liver palpation begins in the right iliac fossa. It starts at the edge of superior iliac spine using flat edge of hand, precisely the radial side of right index finger. Move the hand 1 centimeter superiorly from the right iliac fossa towards the right costal margin. Palpable liver edge low in abdomen suggests gross hepatomegaly. Locate and describe this edge. Palpation of gallbladder can be attempted at the right costal margin, in the mid-clavicular line. Tenderness suggests a diagnosis of cholecystitis. Spleen palpation can start in right iliac fossa, starting at the edge of the superior iliac spine using the flat edge of your hand. Move the hand 1 centimeter superiorly from the right iliac fossa towards left costal margin with fingers aligned with the left costal margin. In healthy individuals, you should not be able to palpate the spleen. A palpable spleen at the edge of the left costal margin would suggest splenomegaly. Abdominal auscultation often is difficult in the active and uncooperative child. Auscultate abdomen, making sure the stethoscope diaphragm isn't cold prior to it making contact with the child. Auscultate over at least 2 positions on the abdomen to assess vowel sounds. Normal vowel sounds are typically described as gurgling. Active vowel sounds often are heard in children with gastroenteritis. Tinkling vowel sounds are typically associated with vowel obstruction. Vowel sounds are decreased or absent in patients with appendicitis or peritonitis. Absent vowel sounds suggests ileus. To be able to confidently state that a child has absent vowel sounds, you need to auscultate for at least 3 minutes. Perfusion. Perfusion helps detect mass lesions and organ size. Solid or fluid-filled structures, such as a urine-filled bladder, produce a dull sound to perfusion. Gas-filled loops of bowel produce tympany. The presence of shifting dullness is suggestive of ascites. Perfusion should begin peripherally. At first, dullness will be noted. As perfusion advances centrally, the air-filled loops of intestine forced to the midline by acid fluid will emit a tympanic sound. When the patient turns to one side, please turn to one side, the locations of tympany and dullness shift as the fluid moves into dependent areas.
The abdominal examination in children should always include inguinal and scrotal region. Therefore, the pants should be put down and we must check the whole inguinal area and the scrotal area. Hernias, incarcerated hernias or testicular torsion may be causes of abdominal pain and discomfort, and often these conditions are surgical emergencies. Hernias are more common on the right side. A history of pain, swelling, presence of a mass in the groin region are very significant. The bulge commonly occurs after crying or straining and often resolves during the night while the child is sleeping. We must ask some questions to the parents. For example, how long have you noticed the discomfort, some swelling, mass or pain in the inguinal region? Can you push this mass back with your hand? When we observe the child, usually we do it in standing and laying position. A rising of abdominal pressure could be made by asking child to cough while our fingers are placed over the inguinal region. Besides inguinal region, we always check the scrotal area. We check if there is some scrotal mass by inspection or palpation. If the patient or family provides a history of painful bulge in the inguinal region, we must suspect presence of incarcerated inguinal hernia. The child could be fuzzy, unwilling to feed, or constantly crying. The skin overlying the bulge may be edematous, erythematous, or discolored. Any hernia mass that is standard to palpation or associated with vomiting should be considered possibly strangulated. That means that we have compromised vascularity or entrapped bowel, and no forced attempt should be made to reduce it manually. This condition represents an acute surgical emergency. We also must consider the possibility of testicular torsion. Here we see left and the right testicle positioned normally in the scrotal sac. The size is normal, there is no pain, the skin is looking regular, and there is no sign of testicular torsion. But if we have a history of sudden severe pain in the scrotum, abdominal pain, swelling of the scrotum, nausea or vomiting, and testicular position higher than normal or at unusual angle, we must think about possible testicular torsion. In that case, testicular torsion is very suspectable as an acute surgical emergency, and further examination as color Doppler, ultrasound color Doppler should be made to rule out this condition.